Welcome to the Architecture of Healing, the podcast where healthcare strategy, design, and operations come together to shape environments that support care delivery and healing. I'm your host, Chase Miller. Today, we're joined by Michelle Mader, Managing Director of Healthcare Strategic Advisory Services at Ankura. Michelle works at the intersection of mission and margin, helping health systems make critical decisions about where and how to invest limited resources. In our conversation, we'll explore how hospitals and health systems are balancing access, cost, and innovation, from the impact of legislation and mergers and acquisitions to the promises and challenges of healthcare technology. If you've ever wondered how strategy and finance shape care patients ultimately receive, this conversation is for you. Let's get into it. Welcome to the podcast, Michelle. It's so great to have you with us today.
Thanks, Chase. It's an honor to be here.
You are the Managing Director of Healthcare Strategic Advisory Services at Ankura. Tell me a little bit about that, what that looks like for you. What's that role entail?
Yeah, no, absolutely. So, Ankura is a management consulting firm, and we do a lot of healthcare across the spectrum. So the spectrum or the practice that I live in is really around capital deployment. So we advise large health systems, pretty much domestically and a little international, but mostly domestic, on essentially how to spend their money, where to spend it, what to spend it on, what's worth doing. I think what makes us a little different than most management consulting firms is the fact that we're very focused on collaboration and prioritization, right? We're collaborating with our clients, we're partnering with them, and then we're really trying to help them prioritize because, everybody wishes they had all the money in the world and nobody does. So with tight budgets and lots of needs, the need for prioritization is pretty paramount.
Yeah, that seems really difficult. Like what's one of the biggest challenges that you encounter as you're trying to help prioritize a very finite amount of resources for a pretty much infinite amount of priorities?
The larger the system, the more the needs are, right? From that standpoint, healthcare is both a business and it's humanity from that standpoint. So that's where the rubber meets the road, right? We have to be viable, financially viable within the market in order to provide services to the public and to be safety net locations, to operate freestanding EDs, to be able to do timely surgeries. That requires buildings, it requires staff, it requires technology, it requires money, at the end of the day. And so I think where we really try to help clients is look at what are those areas in which you could invest that have a return that allow you to invest in areas that don't necessarily have a return. It's kind of like the way healthcare's set up. Those of us who have commercial insurance, we subsidize those that are on governmental plans like Medicare, Medicaid, children's, things of that nature. So it's sort of the same idea. We help them prioritize projects that are needed and required for both safety and infection control and access, while also making sure that those investments are good investments that help support the overall system to do what they need to do on the mission side of things. Every health system has a mission, and that mission's around humanity and servicing the public and providing healthcare to their local communities. So it's like handling their investment portfolio. Where do we invest to make money, to invest in other areas that don't necessarily make the same margins?
So does that look different with different types of organizations, for example, for-profit organizations versus non-for-profit organizations, and the different ways they operate in terms of their business?
So as you can imagine, most health systems in the United States are not for profit. They're either local community mission based. Some of them are religious based, right? They came out of the religious part of the sector, and so there's various different agendas or missions for these. And not for profit and for profit back in the day were very different in what they focused on. Over the years, it's kind of collapsed in that gap. And the reason is they're both trying to provide great healthcare to their local communities at an affordable cost and to keep the doors open. So whether you're doing it for, a faith-based mission, you're doing it for a local community humanity, or you're doing it to provide dividends to your stockholders, you're still providing the same essential services. Just your drive is a little different depending on what organization you're with. But at the end of the day, what I find in working with both not-for-profit, faith-based, and the for-profit is that everybody is out to make sure that people have access to good quality healthcare at the most reasonable cost they can provide it.
And I asked that a little bit thinking about what's recently happening here in Indiana with the legislation to cap not-for-profit billing at 200% of Medicare and Medicaid. And that's proven challenging, and it doesn't go into effect for a few years. But just seeing how that's playing out here locally, and I was even in Pennsylvania last week, and they brought it up as, oh, this could be a bad precedent over here. So we're watching you guys. Have you seen kind of different states? Like, how do you navigate that in different states and different local legislations? I know Maryland's very unique in what's happening here versus, say, on the West Coast. What does that look like, and how does that impact that strategy?
Healthcare, I wish I could say it was like a simple industry, but it's not, right? It's highly complex with middlemen and insurance companies, with the majority of the public rolling onto government sponsored plans, either because they are baby boomer or they have Medicaid, or to even your gig workers who are going out to the marketplace, which is heavily subsidized or was heavily subsidized by the government. So just depending on who you are and what your needs are and the way that you're accessing healthcare. So between governmental payers, between your insurance companies, between high deductible health plans, which you're footing the bill for, there's all kinds of metrics and ways that you can support your healthcare needs, either personally or for your family or even your local communities. And the challenge has been that as our population has grown in various areas, and more importantly, as it's aged, some of these plans were never really anticipating the lifespan of an average American to grow so substantially. It wasn't expecting that people were retired and on Medicaid or Medicare, maybe Medicaid, for 30 to 40 years, right? That was never anticipated in the 1960s when they were developed. And so the challenge has been is we've seen rising costs across the board for everyone, for you as an employer, for you as a patient, for your insurance company, for your health systems, for the government in general, rising costs that haven't necessarily met the health metrics of other first world countries. In other words, we have the highest cost metrics and in some areas, some of the poorest outcomes in general. So this dichotomy has been what the American public has been trying to solve for at least 80 years at this point. Really post-World War and into the industrial area where hospitals became out of the home and into an institution, into a building. When they went from giving your doctor chickens to come and help you to giving your doctor money. When we evolved from taking healthcare out of the home and local communities and from the family metric into a profession, when that evolved, we had to figure out how to pay for it. So this is what we've been grappling with for a while. And unfortunately, what we see coming is that more and more people are going on to government-sponsored programs. So if you're trying to keep taxes low, if you're trying to reduce those rates, you got to figure out a way to pay for it, which means that some people subsidize other people. So what Indiana is talking about is really capping essentially how much providers can make 200 or something odd plus Medicare and Medicaid. And the reason is because those numbers right now can be 3, 4, 5x. In other words, insurance is really, and the public and the patients are really starting to subsidize the rising costs because the government's just not doing it anymore and can't afford it without substantial changes to the financial system and or the tax base. And so as government has says, look, we can't keep funding these rising costs, insurance and providers have shifted that or tried to shift that to commercial. And where does commercial shift it to? Employers. And employers shifted to who? The patient.
So how then are the states responding to that additional burden that is being pushed down to the patient?
Their legislative bodies are looking at their budgets, their tax rolls, right? The money coming in and saying, what can we afford to provide? And how do we cap it? Because at some point we have to draw a line in the sand, and we're trying to not only provide great tax rates to encourage employers to come into our cities, into our state, to keep people here from an economic standpoint, but we're also trying to make sure they don't get gouged with high prices too, as from a consumer standpoint. Just making sure the consumer is getting a fair deal. So there's lots of different things happening across the state. You brought up Maryland. They are the poster child right now for capped rates. And then, the 1960s, really the 1970s, they basically came out and said, look, every provider gets the same amount of money, right? Regardless of whether you're an academic medical center or you're a critical access hospital, everybody gets paid the same for everything. And so they did it to hold their budgets at a state level. They just They were unwilling to pay different people rates for various reasons, and they thought that everybody got the same. An MRI in one provider is the same MRI cost as another provider. In most states, that's not the case.
Yeah, that's so interesting. Do you see that as you're looking at different decisions, say for example in Maryland versus other states, do they have different challenges in how they prioritize because their revenue looks a little bit different or is more quote unquote predictable?
A little bit. So you have states that are losing population, which means they're losing revenue. So think of the Northeast quadrant. Lots of outmigration, lots of, people leaving various, particularly mid to smaller cities in the Northeast. The property taxes are high, the cost of living are high, and they're looking for better and warmer weather, right? So for states that are like that are losing population, it's not a great picture, right? Because who's staying? The people who are staying are the retirees, the people who are on pension plans, the people who are government, sponsored healthcare plans, Medicare, Medicaid. They're staying for the most part. You do have some retirees relocating, but who are really relocating are the businesses, right? The young families who are looking for a lower cost of living for where growth is at into bigger cities. So the areas that are losing population, that's hard. Those states, that is really hard, right? Because they're losing a tax base and they've got increased utilization of healthcare because of who's staying from that standpoint. Now, let's look at states like Florida or Texas, who have had double-digit in-migration from California, from the West Coast, looking for a lower cost of living to better seasonality and better weather, right? In Florida to things like that. Those states are looking at great tax enrolls. And so they don't have to raise their property taxes in order to cover the shortfall. And thus people want to move there. It's the cyclical economic cycle. And so for states that have great population enrollment and great population numbers, they're able to balance retirees and Medicare and Medicaid, with new revenue. For those states that don't, their state budgets are much, much harder. So each state is different in their profile and the percent that are under Medicaid and Medicare, those who have high deductible insurance and those are employer sponsored plans. Each state's a little different. So each legislature is looking at basically really their economic and demographic profile and trying to figure out what works best for them.
As we look at those competing pressures, you've got this governmental or legislative pressure coming down, kind of limiting how much you're able to bill for and things like that. And then you've got the pressure of the patient and treating the patient, but also making care affordable and the best care that you can possibly provide. And then the payers and all those different factors. What does it look like with an organization where they're trying to thread the needle? They're trying to improve care and deliver it at a lower cost. What are ways that you've seen and you kind of help advise organizations to do that with new trends in healthcare? What operationally, staffing, even into the facility, how are organizations starting to tighten up the way they operate to provide care at a lower cost?
Yeah, no, absolutely. So I think it's good and there are lots of different ways, as you can imagine, but there's a couple of core things that I think most organizations are focused on right now. So if you look, just a really quick history lesson, if you look back several decades, right? So let's go back to the 1940s, right? When we started really transitioning into the industrial area where we had employers who couldn't increase wages, so gave health insurance as a benefit instead. That's where health insurance came from, right? Is that we can't increase wages. And so therefore, what other benefits can we provide employees in order to recruit them and entry into healthcare? So let's just go back to the 1940s, right? The 1940s, 50s, and 60s were all about giving access. You had large employers, large manufacturers coming in and giving healthcare as a benefit instead of wage increases. And so what needed to happen was an explosion, right? So if I'm giving you health insurance, I'm giving you health care, then you gotta have to have a place to do it. So that entered in the Hill-Burton Act, which most of, those of you listening know, right? That was done in 1946 and it exploded hospital building. The Hill-Burton provided lots of dollars for infrastructure so that we could see people who were enrolling in masses into employer-sponsored plans. Then so we call the 1940s, 50s, and 60s sort of the foundational era. This is where we established the foundational structure and infrastructure of the healthcare industry in America. In the 1960s, it was like, okay, well, now employers have jumped on board, but what about all those people who aren't employed? What about the poor? What about the retirees? And what about the kids? They need access to healthcare too. Well, in 1965, we established Medicaid and Medicare to cover those people for access. Employers were doing it. There were groups that were being left out. We included them. And then in 1967, we included the kids. So in the 1940s, 50s, and 60s, we created the foundation and we made sure that most populations were covered one way or another for access to healthcare. So the history lesson goes a little further. And so the 70s, 80s, and 90s was all about expansion and making sure that various populations and various groups of people were covered. So you got EMTALA, meaning you couldn't, that when you moved into an ED or saw an ED, they couldn't dump you onto someone else or not provide care. That's a right. You had HIPAA that regulated people's rights around data and, information and privacy. And you actually had in 1973 an HMO Act that started to regulate, right? Like to make sure people got access to care. So the 70s, 80s, and 90s are all about access. Well, that explosive infrastructure, plus all these people having access and rights to healthcare, yielded high cost, as you can imagine. So then you enter into the 2000s and the 2010s era, and it was like, whoa, wait a minute. We are really spending a lot in healthcare. We got lots of people enrolling into these access programs. How do we start to control it? So enter in the MMA Act and Macro Act and the HCAs. You have all of these things that are trying these pilot programs to provide access, but control cost from that standpoint. So when you think about sort of what's happening right now legislatively or just the trends in general and what organizations are trying to manage, how they're trying to thread the needle, this needle's been being threaded for generations, going back, 60 years or so, is being threaded at various different levels. We are now in the cost control era, big time. And so for the last 20 years, we've been really around how do we control access, right? That's what the ACAs are. How do we get to value-based care? How do we monitor that people get to lower price points, et cetera? Really now what we're talking about with value-based and maybe possible caps, like if you look at CMS, the AHEAD program that's going to roll out next year, or this year, if you look at the TEAMS program, it's to really make sure that we have cost control while still maintaining some level of access. And so that's what's happened. So regardless of your affiliation, political party, whether you're blue or yellow or red, it's just an evolution. Healthcare has been an evolution in what we're trying to tackle. And every generation, every era had its own challenges moving forward. So right now, what we're doing with organizations is really looking at how to control costs. And that's access. So the explosion era of the 1990s and the 2000s was as well, goodness, we need access points everywhere. Like I need mammography everywhere. I need, freestanding emergency rooms everywhere from that standpoint. And that's great, except for the law of economics tells you that you have to have economies of scale. In other words, you have to have revenue to cover fixed costs. And a lot of those have low utilization, low revenue, and high fixed costs. We've had double-digit growth since 2020 in just construction costs. So the more that those grew, the more revenue we have to produce inside of these assets in order to cover the cost so that it's viable. So what we're seeing people do is really start to restrict access to some degree. If you've got a mammography location that's only seeing patients 50% or less, they're collapsing into another center that's larger, that they can manage more people. They can see more people at a lower cost price point. If you're looking at taking cases from inside the hospital to outside of the hospital with an ASC strategy, it's the same idea and giving them access, but making sure we can do it at a lower cost point. So what we're really seeing is people start pulling back access and being much smarter about what services they're providing and where. Now every challenge has a plus and a minus. The minus is that we're losing things like OB services in rural America, right? Because we just, if you can't deliver several hundred a year, it's not worth the provider being located there, and their competency is not great. If they're not doing it all the time, they don't get as skilled at it. So what we're seeing is some of these key community services in rural America are collapsing into larger regional centers, putting a lot of healthcare deserts out in America. And that's just the fact of people playing economics. They're trying to handle the staffing challenges as well as the high cost of investment into those arenas. The other area we're seeing to try to control cost is around standardization. So we're limiting access. We're collapsing into economies of scale. We're getting really tight on our fixed assets. from that standpoint to be able to control costs. If everything looks different, it's very hard to plug and play. It's hard to plug and play technology and machinery. It's hard to plug and play staffing who might need to rotate around to various locations. It's hard to plug and play standardization and care protocols and in operations. If everything looks different, if they're all individualized and unique, then all of a sudden your variability increases. And what we know is that cost increases with variability. It just does, right? I mean, Ford told us that 60 years ago in the manufacturing, right? The more you standardize, the lower price point I can get to mass production. Well, it's the same thing, right? Right now, unfortunately, healthcare is trying to get to the Walmart theory, which is low cost, high volume, right? So where do we see high volume and where can we get to low cost?
So on that point, with all of these smaller, more rural healthcare organizations contracting and maybe not being able to be profitable, we see this landscape of mergers and acquisitions. And you think about these large systems that, have some level of standardization across many facilities, and they're coming into rural communities and acquiring some of these organizations. Do you see that as a good thing? How do you feel that that's going to change the overall landscape as we see even mergers with across the country with, Wisconsin and North Carolina, and small scale acquisitions, large scale acquisitions? How does that change the landscape and then also further drive standardization?
Well, on the standardization, I'll hit the easy one first. On the standardization, it's awesome, right? Because they have the scale to standardize and uphold those standards, right? In other words, you have the corporate staff, you have the corporate policies and procedures, you have the corporate checks and balances to make sure that standardization holds. When you don't have that scale, it's one off, right? It's one director trying to manage all of it, and then thus when a provider wants it one way, they just give in. And then once you give in to one, because there's nothing to fall back onto, then it's like a free for all, right? So the larger you get, the more standardized you can become, the lower the cost point. So standardization with large systems is a lot easier to accomplish than it is with smaller ones. And I know that sounds crazy, but it does work that way. The other area that we see with M&A that is promising is the fact that you centralize so much of the back of the house support functions, right? Think of finance, think of HR, think compliance, think of medical affairs, think of legal and those kinds of things. So you're able to collapse those into more of a corporate structure to service more people. Again, economies of scale. So you're getting more productivity out of per FTE, et cetera. Now, ideally, in an ideal world, this would lower overall costs. Unfortunately, we have not seen that actually be the case. That when people merge megasystems with megasystems, we don't actually see the price point go down for patients. And there's a lot of factors for this in general. But that overall has been the trend, which is what the Biden administration, right, really focused on with looking at in-market consolidation. Because what happens is that in-market consolidation, so let's say I live in Charlotte and we have Advocate and we have Novant, right? If those two were to merge into two behemoths in the Charlotte market, they would have unprecedented market power. And those who have unprecedented market power can start to really dictate price points and insurance reimbursement. Medicare, Medicaid, and of course, nobody's going to negotiate a lower price for the services they provide, right? They only want to increase their price because that gives them more margin to do other things they want to do. So that's what the Biden administration was really focused on. And in market is they don't mind if people are jumping markets, like going from Charlotte to Illinois in the Chicago market, because it's two different markets. So you don't have that much power, market power. But in same markets, they really looked at saying, hey, from a capitalistic standpoint, you can't start to dictate pricing. Like it never lowers prices. It only increases prices per patient. So M&A, like anything else, has its pros and cons. The standardization is being helped through M&A, but maybe not cost control as much.
Going back to access and then also with standardization, we're seeing this onslaught of technology in healthcare spaces. That is dramatically changing the way care is delivered, the way spaces are designed, built, staffed. What are you seeing in terms of the integration of technology, the deployment of technology, and how that starts to reshape that cost model?
So right now, for anybody who's listening who is on Epic, right, who is the market leader in technology, you guys know Epic's not cheap, right? So it's sort of the same, the sort of same continuum. Technology right now hasn't reached scale in healthcare to be able to really drive down cost. It's an incremental add right now. It's one more thing because we just haven't gotten to the place where we have one healthcare medical record for the United States. I'm hoping maybe one day we get to that place and maybe it's epic, but we haven't gotten one. So it's always a one-off. So again, the more variability you introduce, the more cost there is. And right now there's a ton of variability in healthcare IT. I think the biggest concern we're seeing right now is that people being proactive in how they plan the integrations and then really having the infrastructure to handle cybersecurity. That's the big risk right now. Outside of the fact that we're struggling to get an ROI in a lot of our technology investments, again, variability on that front. We're struggling to get ROIs, but then you overlay the risk factor around cybersecurity and the potential for down operations or the potential for misalignment on the technology side. It's pretty interesting right now. So I know most of the providers are really focused on making sure the systems they have are secure, particularly when we're connecting to each other. So every connection point opens up a door of potential cybersecurity risks. And when I'm transferring data from one system to another, that's an open door versus having one closed system. So that's an area that we're seeing, again, around cost control, because for every one of these leaks, for every one of these patient issues, it is enormous cost to the system legally and just in operation. So those are some areas we're watching. But again, we're trying to get IT to a scale where we actually think it will drive down or drive up productivity and drive down costs. I don't know that we're seeing that in mass yet. In some areas, yes, but in mass, not yet.
With that technology piece and shifting into the built environment piece, those they want to work together, and it's really hard to bring them together, and in some ways they compete as well. And so eventually when that technology piece becomes cheaper than the design and new construction piece, that's when you start to see that big swing of these new technologically driven care models, virtual nursing that's going to reduce your staff needs, that's going to reduce the amount of space you're going to have to build and construct. It's just really interesting to think about these concepts and how they start to kind of trickle down throughout organizations over the next 5 to 10 years.
That's the dream, right? And I say that to maybe an audience that's listening that's like, hey, that's my job. And to some degree, my job too. Who knows? ChatGPT might be your next health consultant. Who knows, right? From that standpoint. But here's I think is the gist. We can't design and build buildings and take them down fast enough. We just can't. When you decide to do a patient tower or a new replacement hospital, that's a 50 to 100-year investment decision you're making. However, technology changes on a dime. We know that. ChatGPT came out in November of 22. Guys, it's not even been 3 years yet. And the revolutionary components of what it's doing to whole industries is amazing. And so what I think the promise of technology is that we can potentially lower the fixed costs for healthcare in general. And guys, really, that's us. That's bricks and mortar, right? That's buildings, that's hard assets that are really the cost drivers long-term and maintenance and depreciation and all those things. We need technology to get cheaper to make it more affordable so we can leverage it this way from that standpoint. But think about it. If we can keep patients at home by leveraging technology, we don't need as many inpatient beds. If I can triage more on the road at home, things that people don't need to go to the emergency room for, or even to their nearest pharmacy for, that's saving costs for the healthcare system in general. So, unfortunately or fortunately, the PDC is posed to, utilization of assets is changing rapidly. We're already seeing this. It's not at massive scale yet, but here's the conundrum. In trade show like this, as much as we have the downward pressure of technology asserting on utilization, in other words, people coming to a building is less because they can use a technological solution for their need, right? We also have a growing population who needs more and more healthcare. So this is where the two axes cross. And so, 10 years ago, you could say, well, we're just going to need less beds. And maybe in some markets we need less beds, but in a lot of markets we need more, because the rate of reduction in utilization from technology is not keeping pace with the rate of disease prevalence and aging population. So we're still building beds because we still have a lot of people aging, getting old with a ton of comorbidities, and are living 10 years longer, 15 years longer than we ever thought they would.
Yeah.
And in those
Yeah.
last years, they use the most healthcare, right? The most, if you take a person's lifespan and you say, when do they spend the most money on healthcare? Guys, it's in the last 5 to 8 years of their life. They spend the most amount of care. And that's when they're the sickest. That's when they're the most complex. And so what the promise of technology is that one day technology's adoption and pressure around utilization to reduce it will outpace the population trends. But for the next decade, at least for the next decade, as we watch the baby boomers rise and come in, and then don't forget the millennials behind them, right? They're just as big for the next decade. We're going to see more bricks and mortar because we're going to have to. The promise is maybe the millennials will be more technology driven and less bricks and mortar. Because again, the whole idea is to reduce fixed cost and therefore make more margin or reduce overall price point for patients. And that's the promise. We'll see if we get there.
Going back to the idea around access and thinking about, in the 80s and 90s, just providing access everywhere, and then taking technology today, moving into, the early 2000s, let's deliver care, lower cost, let's try to rein that back in. But it almost feels like in many ways, technology is allowing better access in, home health and home care and pushing things out to more localized communities in a way that allows you to rein the costs in some senses. Do you feel like that is the case, or people are just ignoring something to jump on the latest trend?
We should talk about this in another episode for sure. But here's where the big challenge is. The structure of the current financial system within healthcare is beyond complex and broken. And so let me just give you a real world example. The promise of the pandemic, nobody liked COVID, but the promise of the pandemic is that we, in a matter of months, like April to June of 2020, taught the general mass public of hundreds of millions of people that going to the hospital was not where you wanted to be. You avoided the ED because the odds of you catching COVID were going to be high, right? You avoided being admitted because people caring for you, people were dying around you, right? So we taught them not to use the hospital as primary care, not to use the hospital as urgent care. And so what did it force them to do? When you were sick, you were looking for anything and everything to do outside of the hospital. I was calling, telehealth. I was going to my local pharmacy's, physician provider. I was self-diagnosing myself on Google, right? Like I was doing everything I possibly could to avoid the hospital, only going there when I needed to. That had huge promise and something that needed to happen. Then there was the promise of telehealth. Okay, we just taught everybody not to come to the hospital anymore. If we can see them more efficiently and cost effectively in telehealth, that's the way to do it. So telehealth ramped. In 2020 and 2021, we saw double-digit growth in telehealth and reduced utilization. I mean, it wasn't until 23 that we started to recover ED visits back to pre-pandemic, right? For 3 years, we had depressed ED visits because we taught the population this. Unfortunately, here's where the rubber meets the road. For your provider to see you in telehealth, they get $50. So you're going to call and I'm going to talk to you at 2:00 this afternoon and I'm going to diagnose that you've got a sinus infection by all the symptoms you're telling me, right? And I'm going to write you a script and I'm going to send it over to CVS and you're going to get your antibiotic for that sinus infection. They get $50. Insurance has negotiated $50. I might have a $10 copay. Great for me as the patient, not great for the provider. They just spent 15 minutes making $50.
It's the exact same thing. It's the same thing they're doing in the office, right?
Well, but if I come into the office, if I see you in an exam room for the same 15, guess what I can bill? 150. And so there is no financial incentive in the current system for providers to leverage technology because financial reform hasn't followed behind it, right? Nothing changes people's behavior more than money, right? So yes, we have the public educated. Yes, it's best for the physician. They're not exposed. Yes, it's great for the patient. But until we can align the financial incentives behind that and financial reform in mass, that's the challenge. This is why value-based care keeps coming up. Because in value-based care, everybody is financially aligned to do and to see people in the lowest cost setting. Not to do the bare minimum. We're not talking about doing the bare minimum. We're talking about seeing them in the lowest cost setting. So in that scenario, If I got paid $150 to talk to Michelle for 15 minutes, I'd rather do it over the phone because I don't have a fixed cost of an exam room. And that means I make more margin. But right now, it's all variable. It's the Walmart theory. I got to see volume and enough volume to cover my fixed costs in order to make margin. So low volume or high volume, low cost is the name of the game. We got to get out of the volume game, right? Like that's the thing. Until we get out of the volume game, there's no financial incentive for people to move to lower cost sites of care or to leverage technology, which is why technology, we are we're one of the slowest industries in adopting it.
I think I know where you're going to go with this, but if you could redesign or change one thing, about healthcare in general, what would it be?
If I was, the fairy godmother sitting in Cinderella's in Cinderella, the healthcare industry, and I could wave my wand and just create an environment, it would be really around financial reform and access. That we incentivize people to get care in the lowest cost setting and that they have the appropriate care in the amount of time needed. The challenge with universal medicine across other industrialized countries is, people hear about it, right? The long wait times for an MRI, the long wait times for a surgery. You got to get in the queue. And so it would find a balance between how the healthcare system is financially structured. Maybe that means we don't have a middleman anymore. Maybe that means that we eliminate some costs, but making sure that there's access there too. And technology has that promise, right? That's the promise of technology is I can provide access, can talk to you and get you that script for that sinus infection, but you don't have to come into an exam room to do it. You don't have to drive 5 minutes down the road, and I don't have to build a primary care office to be able to accommodate you. We just need financial reform to go through it. And that's what every administration since the 1960s and 70s has been trying to achieve. What is that balance with access and right versus the cost of doing it? And, some people have been predicting that we've been hitting a breaking point, and a lot of generations or a lot of administrations thought the ACAs would do it. They didn't. Now we're trying to see if the new CMS ahead and Teams models are going to do it. We'll find out. But with Obamacare tried it, right? The Clintons tried it. Every administration, every generation is trying to find this balance. And here's what I think it boils down to. Until the American public decides that healthcare is a privilege or a right, you'll never solve it. So some countries have said it is a right, and there is basic, minimal, universal care that everybody has. And other countries have said it's a capitalistic society. You pay for what you get. If you can afford it, great. If you can't, you don't. America, we like to ride that fence. We have a foot in both camps. And what's happening is that in the 1960s, the foot was heavily in the employer camp, right? One side, the capitalistic side, was heavily weighted, and we had some in the right side, the government-sponsored universal care at some basic level. As we've seen the demographic shifts, as we have less kids, as our seniors and our parents and grandparents get older, and as we're keeping people alive longer with pharmaceuticals and interventions, that right shift foot is getting heavier and heavier and heavier. And so that's what we're trying to balance, is really the American culture and mindset. And again, I think many generations after us are going to continue to try to find that balance until one day it swings one way or the other. But that's really what we're straddling, is whether healthcare right now is a right or a privilege. So, there are a lot of things we can do in the middle, and we are trying around access, around margin, around standardization, all of the things. But it's just, trial and error until we figure out what works or until something significantly changes.
I love that. That is such a fundamental question. Is healthcare a right or a privilege? I really appreciate that perspective. Let's jump into our lightning round, rapid fire style. What is one of your favorite healing spaces?
Outdoors and on a swing.
Yeah.
Or back of a motorcycle. Does that count too? Right?
Absolutely.
I'm
absolutely.
super stressed.
Wind in your face.
Yeah, it's a super stress. I find a swing. I don't know if it's like hypnotic or what, but a swing and being outdoors. Those are my healing places.
Nice. What inspires you outside of work?
Oh, my children. Do they inspire me and frustrate me simultaneously? Absolutely. It is fascinating to watch the next generation grow up. I have 2 daughters, and just watching them evolve into being young women and into adults and all the things that are happening right now. So it's a fascinating world to navigate. But if I'm not working, I'm being a mom.
I love it. What is one book that has changed the way you think?
It's not a book. It is an article that I read probably a decade at this point. You can find it if you were to Google it. It's called The Corporate Athlete. And it talks about that to succeed in, corporate America, to succeed at entrepreneurship, to succeed at whatever you want to do, you have to tackle it like you're an athlete. And the reason why it was so impactful for me is it just didn't focus on learning new things or skill sets or how to navigate, the professional world. It focused on, essentially mind, body, and spirit, that they all have to be athletic. You have to train. You have to train to work. You have to train in your profession. You have to train to be able to handle life. And so it's called The Corporate Athlete. It's an article. I forget, one of the big journals, academic journals wrote it. I forget which one, but you can Google it and find it. But I read it and was like, all right, now I know what I need to do. Because it's out of balance all the time. And I never approached it like I was an athlete, like I was training. Like, are you kidding me? I don't have a marathon coming up. Like, from that standpoint, what do I need to train for? You actually have to train in order to do these jobs, for sure.
Yeah. It's not easy.
It is
not easy.
Nope.
I will find that and I will put a link down in the show notes for everyone to have easy access to that. And then lastly, finish this sentence. The future of healthcare is blank.
The future of healthcare is personal. Is how I would finish it. The future of healthcare is personal. With the advent of technology, and particularly around the gene therapies and things like that, personalized medicine has come. And so when we talk about standardization, the future of healthcare is we have to standardize 80 and we have to manage the other 10 to 20%. Right? Those are the unique things. But right now we're managing everybody uniquely. And I think the future is we have to stop. We have to start getting into some, like a cold is a cold is a cold, right? From that standpoint, but really taking providers to top of license and really having them work on things that are unique and they're not, when primary care physicians feel like they're script writers, we have a problem. And technology handle that. They need to be focused on people who really need their care, their bedside manner, their management, their chronic disease, et cetera. That's not the general population. That's 10 to 20%. So I think the future of healthcare is very personal. And you might be young enough to be in the standardized personal bucket, or you might be in the unique personal bucket, depending probably on your age and your health in general. But I think it's going to become more and more personalized. And you might not know you're being standardized if we're good at what we do, right? You might feel like you're getting unique. And that you're a unicorn, but in general, we need to get to a place where we're treating mass population in a standardized, outcome-driven, scientific, clinical protocol way, and then everybody else is the unique factor. So,
yeah, cool. That's awesome. Well, thank you so much for joining us today. I would love to have you back in the future to dive deeper into some of these topics, but this has been a really fun conversation. So I appreciate you being here with us and just going for it. Thanks for joining us on the Architecture of Healing. I hope today's conversation brought you fresh insight and inspiration. If you found this episode valuable, make sure to subscribe, download, and give us a review. Want to learn more? Keep the conversation going and head on over to thearchitectureofhealing.com. We've got more great conversations on the way, but until then, keep shaping the future of care through thoughtful strategy, smart operations, and purposeful design.